Good morning. Good morning, everybody. Thanks for coming back. Thanks for being here. Tell you a little story. I was telling my son and my wife a few days ago, there's something going on with my car. I can tell it. I can hear it. It's whining. It's a whiner. Yeah, it's an old car, and I like it, and I just want to keep it going, you know what I mean? Because I just, you get accustomed to a vehicle you just like. You don't want to, it's rusting out, and it's not doing very well, but it's starting to talk to me. So this morning around North Cotner down here, I'm driving and almost locked up. I thought, oh God, it's starting to shake a little bit. And I found out, and opened up the hood, and I found it's got to be power steering. It's got to be power steering because it's got that whine, Mike. Sure enough, I take my cap off, and the power steering fluid is gone. So I'm driving with no power steering fluid. And a minute before that, I was thinking about power steering. Seriously. I was thinking about the spine and two femurs, the things we steer in life for power steering. And then I find out I have no fluid. So the myokinematic part of this course is really fluid, power steering. We're going to talk about muscles that actually steer these three legs. And it was just comical, so my son's got to get a quarter of power steering oil fluid to get in there just to get home. Otherwise, I have no myokinematic power. True story. Right down here in North Cotner, shaking like a leaf. We're going to talk about those power steering rods. There's three of them. Can anybody remember yesterday what those three things that we're trying to steer in life been? Anybody can tell me? 3 legs to a stool. Do you remember the 3 legs to a stool? What were the 3 legs to a stool yesterday? 2 legs in the spine. We have 2 legs in the spine that we're trying to direct with muscle. And in order for you to direct those three posts, if you will, those 3 rods, you have to have some power. You have to have some power. There's got to be some fluid. There's got to be some steering going on. And that power can go up or down when you change position. When you change the position that muscle power is actually providing your column. You start to change the muscle, and the muscle starts to take on a new attitude. Not a new additive, but a new attitude. Still got power steering in my mind. So let's talk about the vastus lateralis. The vastus lateralis, when it's working on a leg that is in a position where you need more internal rotation out of something, or you need something to steer it better because the conditions that the leg is working in are not ideal. In other words, you're either pounding the floor on the right side, or on the left side, you're just kind of using it as a tapper. Where am I in space? That vastus lateralis could be recruited as a transverse muscle. It could be recruited as a internal rotator because of the position it's in and because of what you want out of it to steer you. The psoas muscle. The psoas muscle goes from your spine, your transverse lower segments of your lumbar spine, and inserts into that trochanter, down there into that femur. And if you really think about it, and you're in a position again, Sheila, where your spine is oriented one direction and your feet are not following the 2 A's correctly, in other words, you're walking a straight line, but the orientation of that spine is to the right, you're probably going to use a psoas muscle, not for leg movement, but you're going to probably use that psoas muscle for a compensatory spinal rotator. In other words, you got to get back over to the left side. But if your spine can't get over to the left side because you're out of fluid over there, you're going to use this muscle called the psoas to kind of steady your spine over a new spine, the leg. And now your spine and this leg are the 2 things holding you up. And that is not good performance, because at that point, you're kind of a slave to one side. If I keep driving that vehicle, I'm going to lock up, and it kind of locked up, and all of a sudden I'm going over to my right side and I can't get over to my left side. I have no power. I can't get over there. So I think the analogy is a really good one this morning. That's called myokinematic power. Myokinematic power. Muscle that's put in different positions, either power up or power down your activity. And that's the process of looking at what we're going to do today. That is the process. What are we trying to do? Are we trying to power up muscles to get us over to the left side or to the right side? Neither. We're not. If we keep powering up muscles to get you over to the left side, we have a different problem. If we keep powering up muscles to keep you to the right side, which you've been gifted. In other words, if your steering fluid runs out, you're going to be powered to the right side. That's a given. Your organs are going to drive it, your brain's going to drive it, your breathing's going to drive it. You're going to stay powered up to the right side. That's a kind of a blessing in a way. You can predict how you're going to lock up. You might want to write that down. It's predictable. You walk into the clinic, you're going to predict how you're going to lock up if you lock up. You'll be locked up on that right side. Been more times than not because you happen to be a human. Your vehicle is a human being. So you're going to probably lock up on the right side. So is the answer of powering you up and getting you over to the left side and lock you up over there? No. The answer is you got to power up your spine. You got to get that third issue to move left and right, vibrate, rotate, spin, move from side to side. So shifting, translatory activity. Everything I just described is neutrality. So just for a recap, today we're going to put people in a position so they can learn how to do all those adjectives and adjectives that I just went over by establishing power that moves them from left to right, right to left, so they can transition through this thing called N on your car, neutral. Because if I want to go to park, I got to go through neutral. If I want to go to reverse, I got to go through neutral. If I go forward, I got to go through neutral from reverse. I have to shift. I have to shift that power. So what we're going to do today is I want to go back to this last slide. We had a couple slides yesterday. I said, go home and look at it. We have things that kind of lock you up. Bones that can lock you up when there's no juice, there's no power, there's no fluid getting you out of that locked up state. Bones that lock you up then don't allow you to turn. So the transverse plane provides the power. It's not the sagittal plane. It's not the frontal plane. It's the transverse plane that provides you power. And I'm not going to get into, is it kinetic power? There's different kinds of power. I'm just going to talk about movement, performance, requires transverse rotation. And anything to get us that transverse plane is going to be pretty awesome. And I think you all know that. So with that being said, if there are any osseous or myosseous limitations on getting that transverse plane, we got to take care of that, Mike. And the only way you know what to take care of, whether it's osseous or myosseous, whether you got a rocker arm going out or a fluid you need to add, you got to figure out, first of all, where is the problem? You got to make a diagnosis. So yesterday when we looked at these two pages, AF and FA treatment rationale for the left AIC pathocompensatory pattern. And I think there's a slide after that as well, yes. And if you look at this is the treatment rationale we would use when you know you've got some power issues because of soft tissue problems. So you reposition a patient and you relook at this and you say, okay, if I still have left IR that's decreased compared to my right, my posterior superior capsule, I need to do a posterior superior capsule stretch. I need to get AF and FA adduction. I need to get some internal rotation from my ischial-condylar adductor to approximate and stabilize that pubifemoral ligament inferior capsule, okay? All I'm saying is these are the things that you would consider doing if this is a soft tissue compensatory pattern. So we're back to the days where we went to school. What capsule do you need to stretch out? What muscles should you turn on to help stabilize? This is a nice little sheet for you, Bobby, because if you just can look at that, you kind of know where we're going with the entire day, which is why I want to talk about it a little bit. So if you look at your handout and you see what the first one says, what's in dark letters, Bobby. The first one says if you have decreased IR, you want to look at that posterior capsule and get it stretched out, okay, on that left side. If you go down below, if you have increased ER versus the right side, you might want to work on IC adduction activity. And you might want to work on anterior glute med because you need more IR. Do you see what I'm doing here? In other words, you've made a diagnosis, they're patho. There's something pathologically going on. In other words, they're compensating, they're doing something with that hip they're still locking up. They're still not moving like they should. You've achieved neutrality, you've got neutrality, but something's still not working the way it should. Does that make sense, Chad? The little cheat sheet says, well, just take your goniometer out and look at the range of motion, and it'll kind of tell you where you need to go when you compare it to the other side. So you can go down that highway of life and not be steered to the right or to the left. This, if you want to write on top of this, write the word spine. This is a spinal discussion we're having right now, because you're trying to balance out the orientation of where the spine's at. So if you have a back pain patient, one of the first things you might want to do is get your, put them in neutrality, get your goniometer out, and check range of motion. And then you can even go so far to check strength. That's on the next page. Where are they weak? Where are they not? Now we're playing myokinematics. Now we're saying we're going to use muscles to steer that spine. We already know one we're going to use. It's called the IC adductor and the anterior gluteus medius and minimus. If you go to the other side, it says increased right IR compared to the left. You go to, I think, yeah, there it is right there. Well, what does it say, Bobby? It says, I think I should probably look at AFER glute max to reposition. Remember yesterday I said that's a good repositional muscle? To reposition that lengthened right obturator for hole control. Man, circle that, guys. That is so beautiful to start the morning off. Now I've got my front steering secure. I've got hole control. I've got pinion and rack control. I'm stable. So that tire movement, that wheel on that car, is not stabilized by the wheel moving on that, on that rim. It's got to be stable, or on that. What am I looking for? The brake pad. In other words, it's, what am I looking for, Chad? I can't even think of it. How does the wheel actually attach? Well, from the axle to the wheel, that's not where the stability is, because you got to rotate. It's that rack and pinion steering piece, and that's called hole control. The chassis. So anyway, basically, what we're saying on this one is get your glute max, and now you got the stability that you need. And Bob, if you go to the very next one on the right side, it says if you have an inferior capsule or you have an anterior capsule that needs to be stretched out, you're probably going to lose some right ER capability. So don't be afraid to stretch that out a little bit. And to do that, get some AFER glute max to position that lengthened right obturator, moreover for hole control. So hole control on the right side is a kicker. We really want to stabilize the pelvis with it. The bottom one says AF and FA abduction, posterior glute med to stabilize superior ischiofemoral ligamentous capsule. Is that in dark letters? It should be if it's not, right? Inferior, it is. Inferior capsule, anterior capsule, stretch. Underline those two things. So those are little guidance. So when someone says, these people in PRI don't really stretch much out, we don't. But we do have to stretch some things out called capsules to make enough movement available so that you can move side to side without limitations from soft tissue, especially when there's pathology involved. And I got to tell you, I looked at this last night before I went home with Jen, and we talked about families of muscles, and where do they go? Why did you color what you did? We reviewed the whole thing last night, and I got to tell you, it's still kind of powerful stuff, Jen. I went home and I texted you. I think it's so cool that we look at this. There is no way I cannot get excited about green and red, and get excited about orange and purple. Those colors. They stand for IR and ER. They stand for strength. They stand yellow, integration. It's not that you need to know that for this class, but I really do want you to be reminded that those colors that you used yesterday are going to fit with the other muscles. And we're having you color it not to make sure that you know where these muscles come and go, but look at how much coloring you did. And one of the things we didn't really look at is, do you remember, go back to your right glute max and look at the right glute max coloring before I get into this discussion. Go back to the right glute max, and when somebody finds it, would you let me know what page it's on? Or go back to the glute max. I see it right here, okay? If you go to page 20, number 3 is glute max, okay? What color was that, everybody? Orange. Does that look like a gluteus maximus attachment site? It's not very big. There's not a lot of muscle there, is there? Let's find the other attachment sites. Man, look at that small little 3 on page 21. That's not very big. Where's the other attachment site? On page 26. You guys, it didn't take you a lot of time to color a huge muscle called the glute max. Well, let me tell you something. It's not that huge. But it's extremely powerful when it's in the right position. Does that make sense? It's not that, it's a very very luxurious muscle. It goes way underneath of you. And when it's in the right position, it can do about anything. It can extend your hip, it can rotate a femur, it can pull an SI joint together, it can compress, it can decompress, it does about anything you want it to do, depending upon the myokinematic position you place it in. The myokinematic position of that muscle will change its direction of pull and either lock you up or let you go because it's triosseous. And those triosseous muscles are really big myokin muscles. Last night, Jen and I went back and replayed a little bit of James' tape that when he gave this course on tape, and he did a great job, Jen. And I still hear Jen said, well, you guys are saying the same thing, but I want to repeat what he said. These are your triosseous muscles. They're extremely important for myokinematic control of 3 things, legs and spine. And they do it through a number of bones, 3 of them. What were the other 2 triosseous muscles yesterday? Can you guys remember what they were? Got a beautiful fly flying around, don't we, Joe? What was the other 2 muscles? Do you remember the other 2? Anybody want to tell me? Well, go back to your page 21. Let's look at it. On page 21, what's number yellow? Piriformis. Okay, you don't have to go any further. Stay there. What's the black? Those are your 3 triosseous muscles. And those 3 triosseous muscles, if you go back and you look at your manual someday and you see the word myokinematic, please think of those 3 muscles because they have the biggest power steering on those 3 axes. 2 legs and what? Spine. 2 legs and a spine, along with one other muscle that's not on there called the psoas. We could talk, but iliacus is on there. Do you follow me? So we could talk about the psoas. And the psoas and the iliacus, and I remember these earlier days, Jen, you were around. Remember how I used to be really beefed up on this? There is no such thing as an iliopsoas muscle. Gibby, you're probably as old as most people in this room taking these courses. Remember me talking about that? There is no such thing as an iliopsoas muscle. There's an iliacus and then there's a psoas, and they attach in the same place on that femur. But they both have different myokinematic purposes and properties. The iliacus is a great pelvic floor, great pelvis stabilizer. The psoas is a great spinal rotator when the femur's not what? Moving. It's anchored. So I'm just pulling that out. I want to remind you that when you look at any muscle of the body, just because the attachment site says an I and the O, and it doesn't always have to be grounded, depending on what grounds some of your attachment sites. Don't say ground. What grounds some of your attachment sites? Locked up positions ground you. So when you're in a locked up position, that muscle will now have a new what? A new drive, a new pattern, a new operation, a new movement called a movement pattern. You don't have to be on that floor for a closed kinetic chain to change what you do with that muscle. So what grounds you is you may say, I need to ground myself by driving myself into this hip so I have a reference, a center to move everything off of because I don't use the ground down there for my reference. I want this as my reference. Or I want my SI joint on one side to lock up so I have a reference for that activity I'm going to do around that SI joint that may be locked up on that left side. Do you understand? So when you lock something up, you have a new reference. And to unlock that, you got to go behind the muscle and the neurological system and say, did you ever reconsider going back to the days where you could go from side to side and use proper references for reference? That would be what you do with your appendages. That would be what you do with your spine. When you move through in ranges of motions, you say, that's a reference. That's a bumper. That's an in range. That's as far as that steering wheel is going to go. What keeps you grounded is in ranges of myokinematic activity. That's your references. I've reached my in range. But Sheila, if you never get to that in range, sometimes we just settle into an in range. We'll just stay here. That's my new reference. And all the muscles of your body will know it. And they're all going to have different myokinematic properties, and they're all going to steer you a little differently at that point. I could talk about myokinematics, Jen, for another good hour. I think we just roll off this too quick. This course is called myokinematic restoration, which means the only way you're going to get myokinematic restoration is you got to look at what soft tissue is limiting if you have patho, and what are you using for references called bones to give you orientation for what you're like locking into. And then the third one is strength. You got to do a little strength testing once in a while. You got to check to see if they can do things on one leg. Can they actually operate themselves when they're on one leg? Can they sit there and give you the same amount of strength or effort on both sides when tested the same way? Because if they can't, either they're truly weak with that muscle, and then the question I'm going to ask you, Jacob, why? Why are they truly weak with that muscle? Or are they truly in a position where the myokinematic strength of that muscle can't be realized because of the position that they're in? Another word for myokinematics. So muscle is really important to me versus bone, osseous kinematics, or arthrokinematics, because those last two are totally dependent upon the word myokinematics, position. So when you look at those quadrants and we look at what you're really trying to go after, last night I asked you to go back and look at that, there's four things that you should have looked at that kind of stick out. There are four things: posterior capsule, inferior capsule, IC adductors and glute medians, and the beautiful what? Glute max. Those should have been sticking out. Those should be sticking out all day long today. Those four areas. You bet.
So as I read through that, they all kind of are saying the same, you know, the left internal rotation is left and the right, that's more. And so my question is, what's the reference? Like, what are you, is it based on the range of motion that's considered normal? So
Yeah,
like,
it would be based on range of motion that you could do. A normal 40 degrees of IR, 6 degrees of what? ER. Right. Can you adduct? Can you abduct? Those are references.
So basically it's saying, like, where left internal rotation is limited, your right's normal, you've got 40 degrees of it, and
Yeah,
left is
yeah.
less. So you're saying, I go to this box.
That's correct.
Okay.
That's correct. The other thing is, yesterday, those tests, can we keep going with that? The test, that's a great question. So you compare one to the other in sitting. I mean, it's in sitting position. I mean, you could do it in supine too, which you'd get a little different value, but the arrows would be the same. It's just it's going to be a different value overall because you're no longer in a loose state. You're more in a what? Rigid state, more tight state. Let's go over the other test. Can we do that real quick, Bobby? Why did you look at trunk rotation? Nobody asked a question yesterday about this. Why are you doing the test?
Spinal orientation.
It's spinal orientation. It tells me whether my car is going to be always going to the right side of the road or my left side of the road and kill somebody. It's spinal orientation. That's one question. Do you have the ability to turn your spine both directions the same way? Guys, I don't know, that's kind of threatening to me. That pushes discs out. That gets me kind of cranky. That gives me the inability to breathe correctly. That lateralizes me a little bit too much in my life for liking. Spinal orientation is kind of a big deal. So Sheila, if we do something with myokinematic activity and we try to get a little more IR on one side and a little less IR on the other side, a little ER on one side, a little less ER on the other side, to get that spine to rotate both directions, that's a kind of a cool thing. We're back to the three legs. We're back to what are we going to do to get that entire body to recognize that you have two sets of abs, Sheila. that they got to be working on a spine that's in a regulated state of neutrality. Otherwise, you're never going to get one set of abs to do what the other set of abs is doing. It's never going to happen. I always get concerned when people do this stuff because they don't even realize, Joe, they're doing it on a body that's twisted. You're never going to get out of this. This is a beginning course, right? Beginning course, we've got to talk about beginning principles. How do you do anything you're going to do if you don't have the ability to do it the same way on both sides? Does that make sense? So that trunk rotation is probably one of the coolest tests in the whole PRI Institute. In other words, can you rotate your trunk freely, both directions, at that base? That would be a big question. And we're using this course to steer that spine. This is why this course is so imperative when you look at anything that deals with the spine. What's another thing we did yesterday? Simple. Can you add 3 words? Can you what? Adduct. If you can adduct 5 degrees, can you adduct? The answer is yes. I didn't label how much you should have adducted yesterday. I didn't say your knee had to go all the way to the table, nor does any of your writings say that. But Jen, can we adduct? Can you move a femur? And one of the things that I hope you picked up yesterday was you really got to do what? Eric, you really got to stabilize that innominate. Because if you don't stabilize that innominate, your brain knows it. And you don't know what the tester wants out of you. So you got to reference that innominate. You got to give that innominate some stick. You know, you got to hold it. Because if you let it move a little bit, the patient you're testing is going to move a little bit too to compensate for that little bit of movement, and you're going to get a false what? Positive test. So you learned yesterday, I got to really stabilize that innominate. I got to really get it ground down on that mat, and I've got it. I got to line them up. I'm not going to let that baby move. If you need somebody else to help you with these big legs, go get somebody else to help you. Otherwise, don't rely on your testing procedure because you're not capable of doing it. All I want to know is if you can adduct that leg when you're standing. That's it. That'd be a yes or a no. If it goes 20 degrees and it should go more than that, I'm fine with that. I'll get more because all I got to do is now pull it with myokinematic muscle the rest of the way. The joint's probably there. It's ready to receive it. Yesterday was a day about A. That A has got to receive that F. That A will probably, unless somebody puts some super glue in there or some molding clay, there's probably room for that femur to move in that acetabulum. I'm going to assume there is until proven not guilty. Unless you have arthritis or something growing in there, it should be able to accept that. So I really think that's an important test for one reason. It allows all 3 of those extremities to actually start to what? Respect each other. You're back to 3. If you can't adduct, you're only on 1. The spine is oriented there, that leg is oriented there, and you're down to 1 spine. It's called right leg. You're down to 1. I don't think we really take that seriously. You can't do anything but get down to 1. The next question is, today, can you abduct? We're going to look at that. Can you give me a adduction on one side and abduction on the other side actively? What was the last test we did yesterday? One more test. We did straight leg raise. Did we do straight leg raise, Pat, to stretch out a leg? No, we did straight leg raise to see the State of the Union address. We've got a Republican on one side, Democrat on the other. Are they liking each other? Do they get along a little bit? Which one's tight? Which one's loose? Which one's shooting at the mouth? Which one's not? Okay, we're going to try take both of them up, and we're going to see if they're kind of liking doing the same thing. And Chile, you're just going to mark it down because there's neurological tone, but we're really looking at positional myokinematic tone. If that left leg is oriented to the right side, and I straighten that leg out and I try to bring up, it is going to be limited. Because myokinematically, the muscle that's around the leg is short now on one side and long on the other. That leg is not in a neutral state. You're testing a straight leg raise that's in an awkward state. We never talk about that. But that should be the first thing we remember. That femur is not in a neutral state when you do a straight leg raise if the pelvis is forward on one or what? Both sides. Because if the pelvis is forward on one or both sides, both of those femurs are going to be oriented in which way? If it's rotated on both sides, both those femurs are going to be rotated in. I didn't say rotate the femur in when you do a straight leg raise, because if you do a straight leg raise with the femur that's being oriented in and you keep it turned in, it'll go straight to 90 degrees. Okay, doesn't just make your wheels turn? So all these days that you guys are doing the straight leg raise business in real life to stretch out hamstrings, you realize you're stretching out muscle that's healthy that doesn't want to be stretched out. It's in the wrong position. Why would you do that? If you stretch it out, you just took the floor away from them. They're lost. You just gave them a new reference. It's called the hip that they will lock into because you just stretched them out. You made them touch this floor because you had the problem, not them. Did that make sense? I think we have to start this morning out a little bit like that. Why are we doing this? Why are we doing all this? This strength is going to change. If I have you in the wrong position and I test you out, the muscle that's the shortest is going to be the strongest, and the muscle that's the longest is going to be the weakest. Take a Shirley Sarman course. It's strategy. That's myokinematics of strength. I think we killed it. So those are the basic tests that we went over yesterday we're going to kind of keep in mind. They kind of steer your program. They're the same tests, Mike, that I would use as you go through the program to determine whether or not you're even having any success. Here's what's really cool about PRI, and I can say this on tape. All the things I just talked about will happen in milliseconds. You don't have to wait till next year, week, month, day, or even in 2 hours. Bobby, you understand that? If I put you in a different position, I can step there right away and show you it's changed. And your patients love to sense and feel and see that you just made a change in my life. It's completely there if your body's in the right state. That's what's really cool about it. Show the patient right away. Here's why I want you to do this 90-90 technique that we're going to do this morning. Here's why I want you to sense your left what? He's gone today, Chad, you're in my new hamstring. Here's why I want you to sense that left hamstring. Because with that left hamstring, I can control your vehicle. I don't have to add power steering fluid to you. I don't have to check the air pressure. I don't have to do anything. Every day, could you give me a little gas in the left what? Left hamstring. This is why we got to do it. Because those three extremities will know it right away. And I think we just need to pull that back. Now we're going to go down and go to the next day. Okay? Jen, do you need to crank this up, or how do I get that up? So let's go to where everybody go to your myokinematic function relationships. That's what we just got through talking about, myokinematics. And now I think, Dallas, this is going to make a lot more sense. Let's go through this from a myokinematic perspective, the relationships, the algorithm for this particular course. And if you take a few PRI courses, you'll see that we have these functional relationships and algorithms in the first three courses. And then we even have a few in the advanced integration course, and a little bit of that. Okay, I'm going to ask the word, what does that mean? I'm going to ask the word, why? Why are we doing this? Because we're now thinking about an algorithm, Lydia. Where should we start? What should we do myokinematically with the process that we're going to use today to get to a treatment program for individuals that walk in? Big individuals, small individuals, lightweight individuals, heavyweight individuals, active individuals, and very sedentary individuals. It doesn't matter. I don't care what you do in life. I don't care how much oil you put on your hands every day. I don't care how much hay you put in your hands. I don't care how many tools you put in your hands. I don't care how many mouses you can control. It doesn't matter. Let's just get that established right now. I'm not looking at occupations. That's another nice thing about this course. Pat, you can be anybody. Isn't that cool? This is cool. Because we're going to start off, the first thing I'm going to ask you is, I wonder if you can adduct your left leg. That's the very first thing. Can you adduct your left leg? That's what it says. If you can't, it's got a little plus by it. That means you could not adduct your left leg. Right away, I know you're out of power steering fluid. I know we got a problem. You just locked up. We got a problem. I can't go any further with you with anything I do until I get that corrected first. And what's really cool, no matter what you do in PRI, Joe, the first question is you know down there, can those girls shift their body weight over to the which side? The left side. Can they do that? If they can't do that, Joe doesn't have an athlete to work with. And Joe is really good. She doesn't want to deal with things that are created by performance. She wants to be able to create performance with things that should be there. So why don't we get that established right away? We want to make sure that you can adduct that left leg. We also know that if you cannot adduct that left leg, you should not be able to extend or drop that leg over the edge of the table. Your extension drop test should also be what? Limited. You better hope on a prayer that it's not going to drop all the way down to that table. Because if it drops all the way down to the table, Joe's saying, I got more work. We call that pathology. So if it says negative, she knows, if we go back to that chart we were just on, she knows there's a pathological soft tissue issue. Something's too lax. That iliofemoral and pubifemoral ligament have been overly what? Stretched out. Maybe intentionally stretched out, I might add. Maybe somebody wanted it to go all the way down the table. In my days, we called that the Thomas test. Okay, and I won't get into it today. We're still using it as the Thomas test. To do what after it's too tight, been labeled positive? Stretch. You realize how many problems I'm dealing with people that overstretched out this ligament when in reality it never needed to be what? Touched. So that's the very first line up there that says, can you play the game of Monopoly? Can you even get started with me? Next one's going to say, oh, there's that beautiful spinal orientation. That means if you have a positive adduction drop test, you're more than likely going to have limited right trunk rotation. Let's pray to the good Lord that if you will, that leg and that leg lack of adduction and that leg's lack of ability to not go into full extension will produce a spine that's oriented over to which direction? The right side. Let's hope to goodness it's going to stay there. Because if it isn't, you got pathology number 2. You got an iliolumbar ligament. You got this whole right side that's going to be cranky now because it's too stretched what? Out. Now, we just hit, I think, some of the biggest issues that you're going to see in medicine today. Those two right there. The third one, or the next one is decreased left straight leg raise. Why? Anybody want to tell me why the straight leg raise on a person that cannot drop their femur, adduct their femur on their side, should be limited? Can anybody tell me why? Why, Katie?
Because it's coming from a higher position on the pelvis when it's rotated forward. So
I love the way you said that. It's because the muscle myokinematically is coming off of a position it's attached to that's higher than it should be, is what you said. Would she be right? Absolutely. So would it be fair to say then Katie's going to try to get that position that muscle's attached to in a lower position? Wouldn't that be right? Wouldn't it be correct to say that, here's what's going to kill you guys. Wouldn't it be correct to say to get more flexibility out of your hamstrings then, you want to strengthen and get that hamstring stronger? Whoa. True. I mean, did I do the math right? So what you're saying is I've got to tighten up my hamstring to get more out of my hamstring? Whoa, that's kind of crazy. That's a little different, Chad. I didn't go to school for that. If I want more of the hamstring, what do I got to do, everybody? Stretch it. This is really weird stuff now. Because she just said that attachment site's too high. So she's going to take that very same muscle, pull that attachment site down, and now that muscle has more room for that leg to go what? And now let's multiply that 100% across the entire body. And you'll understand why before you even think of the word stretch to treat, I didn't say stretch to warm up. Should never really be on your mind until you ask whether or not you got the car with enough oil in it. Because otherwise it's in a locked up state. So thank you, Katie. That's right. For that straight leg raise to go up because it's decreased, maybe I got to get that attachment site in a different position. If I have an increased straight leg raise, I already know, underline the word neuromuscular. We already know that that's not even a myotonic issue, Mike. That's not a gamma system issue. Excuse me, that's not a myotonic issue. It's not a myosin-actin issue. It's a gamma system issue that's not activated. You don't need it. You dropped it off. It doesn't resonate anymore. There's no rhythm down there. There's no purpose for it. There's no vibration. It's dead. You have no, and it's just going to stay off. Does that make sense? That's a neuromuscular issue. Let's go on to another one. Your adduction drop test is positive. Let's say you're kind of one of these people that like to stretch hip flexors out because they're constantly on. They never shut off. And that adduction drop test is positive. Well, we know by going back to through what we just talked about that your IR will also be decreased. You'll have decreased left IR. You have an active left TFL, an overactive left FAER. You're going to do lots of external rotation. And you're going to also have restrictive type posterior capsules and secondary to left AFER osseous position. There's a lot of reasons why you may not be able to be able to adduct that leg. So you have also IR issues going on. That would be range of motion issues. So your goniometric measurement would change. And we did that yesterday, Sheila. We sat you up, we said, let's check that. And that's just a summary of all the things that could be going on. So now we got another thing on the table. Myokinematically, before you start to stretch out for internal rotation or strengthen somebody, before you would do that, you'd want to put them in the right what? Position. Here's where I want you to write the word. I would like to have you write one word under this sentence in that column. Think inhibition right now. When it comes to transverse rotation limitations of appendages, or make a mental note of this, when it comes to transverse rotation limitations of appendages, don't go through your days of strength and stretch. Where do you need to inhibit? Something is got to be inhibited. Put that cap on. Something's not allowing that system to work correctly. Something is facilitated too much. And then I want you to write another word down. I want you to think, inhibit, extension. This is a weird class. Wait a minute. I thought you needed hip extension from Chad's hamstring. You do. But to get extension inhibition out of your system, you need to get that extension out of that muscle. A hamstring that extends you is a hamstring that puts you into flexion. A hamstring that extends you inhibits your back extension. Remember yesterday morning, back extension equals greater than 30 degrees of what? Lordosis. You see how this is working? So when I see an adduction drop test that's positive, and then I check my range of motion values of a leg or an arm or whatever you're going to check, I'm going to say, before I do anything more, I'm not going to consider those real values until I inhibit a system that's in what? Extension. Extension. And to inhibit a system that's in extension, I'm going to go after extension from what muscle, Chad?
Hamstring.
That puts your system into flexion. This is the weirdest morning I've ever had. It's getting weirder by the book. Every time he brings something up, it's just the exact opposite of what I'm thinking. Sheila, do you understand what I'm doing to you right now? I didn't say facilitate strength. I didn't say facilitate range of motion. I said inhibit extension. Well, then you're going to say, well, if he inhibits extension, how's he going to get the body into flexion when I extend the hip? Because see, extension of the hip is flexion of the trunk. Flexion of the trunk allows you to shift from side to side and allows you to use all three triosseous systems. 2 legs and a what? Spine. We're back to those triosseous muscles. So I think the rest you can see. Decreased right ER, the reasoning behind that, we went over that this morning and yesterday. I won't repeat that again. Kind of nice little cheat sheet. So that we add it all up. A positive right adduction drop test, it should a positive right, if you cannot adduct the right side, you probably are not going to be able to adduct the left side. That's the first time you've heard me say that this course. I'll tell you, it's going to be impossible to adduct the left side. Because in other words, if you can't adduct the right side, you know that you're compensating for the lack of adduction on the left side. You know your body went into, what was that last discussion we just had? Bilateral what, Chad? Don't say hamstring. Extension. So when you can't adduct the right side, we're pretty sure you're not going to adduct the left side. On occasion, with pathology, you may be able to. But for the most part, you're not going to be able to. I remember giving this course 20-some years ago, 30 years ago almost, and I kept telling people, look, if you find somebody that can adduct their left leg and cannot adduct their right leg, would you send them there? I'll pay the way. I like to see that. I like to see how that person who's in situ, which means all their organs are on the other side of the body, or has had a stroke, I'd like to see that person. Because that's impossible to do if you didn't have it based on the human body the way we're put together. I like to see that. So that's called a PEC patient. And posterior exterior chain patients are patients who cannot adduct on both sides. Should they be able to extend either one of their femurs? No. Would their ER be limited when testing? Possibly. It should be, because both of those femurs are going to be inwardly what? Oriented, et cetera, et cetera, et cetera, et cetera. We ask the question of the day. If you have somebody with a bilateral issue, kind of got one over here, where would you start treatment? Remember, they're a human. You're on the earth, they're human. Where would you start treatment? Would anything in this manual change for a left AIC patient? That means they like their right leg? No, you would still pick up this manual and go after that patient like you would somebody who's only got one side that they're using. You'd start off, you do the same thing. That's called in a car, jump start. Battery's dead. Jump start. I need a reboot. Years ago, my daughter Rochelle would say, Dad, just reboot, you're talking too fast. Shut down, pull the plug, re-jump. That's what we're going to do. We're going to pull your plug, we're going to get you to blow out, and we're going to start the plug again. Plug you back up, get over on that side, figure out where the left side is, because your body will figure out the right side. Just give me the left side and let that metronome start up again. Okay? Those are PECs. That's a quick discussion. Underneath that it says a positive left extension drop test should equal a positive left adduction drop test. A positive right extension drop test should equal a positive right adduction drop test. All those are little reminders that you really shouldn't have one without the other. And I really like on the very bottom, I really like this. Might want to circle this. This is a really big statement. That's today. This is in today. Now we're talking about frontalism, a left AFIR state, a left acetabulum moving on a femur state, A moving on F, an IR state is equivalent to right AFER activity. That's transition. It's halfway in the gait cycle. A right AFIR state is equivalent to a left AFER state. The left AIC pattern, which would be which one of those two? What is called a left AIC pattern? Which one's a left AIC pattern? Anybody? Thank you, Bobby. I'm so glad you're here. So if you want to write down left AIC by that last one, Bobby, you would know then the one above it is a what? Right AIC. Which one are we working towards today? What are we working towards? What are we working to today? Which one are we going to be working to today? Which one, Bobby? We are going to be working towards left AFIR with right AFER, which is a right AIC state. The anterior chain on the right side needs to kind of boot up. How are we doing? Terminology is easy to some. It's easy for me. And why am I making a big deal, Sheila? Because if you get the terminology down the treatment is going to be even easier to understand. Would it be fair to say the rest of the day that we are going to work on getting individuals into a state of internal rotation on their left side? Let's think about the entire day of internal rotation on their left side. That even includes the ribs, which is a different course, and a pelvis, which is a different course. But we're going to just think today, our entire day is going to be structured around getting everybody in the room to think about internal rotation on which side? The left. And what you don't know is you just went into a huge, vast region of internal rotation all over the body, including the head. On which side, everybody, today? The left side. Let's flip the coin. There's two sides. Let's assume today, Chad, everybody in this room is going to respect more external rotation on the right side. Why don't you put that down? I want to write it up. Right external rotation today. We'll even take the words AF out of the category. Everybody in this room wants right ER today. I hope to God you do. Let's get ER today. You want it every day. You want it absolutely, positively every day. You want a glute max to fire up. You want some activity going on where there's external rotation going on through that floor every day, okay? What's the first muscle that should pop in your head on the right side? We did it this morning. First muscle. Let's make this a glute max day on which side? Grab your Cheerios and we'll call it right glute max Cheerios today. What do we want with Tony the Tiger on the left side? What's the number one muscle we want over here? Don't say TFL, that's a flexor of the hip. What's the number one internal rotator we want over here? Somebody yell it out. Ischial-condylar. Let's start writing that Tony the Tiger cereal. Ischial-condylar Wheaties, cornflakes, something. Ischial-condylar, 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 ischial-condylar. One is an adductor and internal rotator, and another one is kind of like an abductor and external rotator. And when we say the word gluteus maximus, think posterior glute med, posterior glute min. Think of the word abduction the rest of the day on which side, everybody? Think of the word adduction the rest of the day on which side? Left. And then let's put the entire appendix around that, which, by the way, it is. The entire appendix is around that concept. Entire appendix. How do you brush your teeth in the morning? How do you carry a child? How do you get out of a chair? What exercises could I use? What techniques could I get a left IC adductor and an anterior glute med and min? What exercises could I pick for a right glute max and a right posterior gluteus medius and minimus on the right side? That's it. That's what you should be thinking about. Let's see if it works that way. Sheila, should we see if it works that way? Go to your appendix. Everybody go to the appendix. Let's see if that's true. There's that myokinematic restoration appendix. It says non-manual technique. Non-manual technique. Left hamstring. Left ischial-condylar adductor. I'm on page 1 of the appendix. I'm right on page 1. I'm following the appendix. Left hamstring. That was yesterday. We're going to do it today. We're going to show you how to use it. Left ischial-condylar adductor. Right glute max. Left glute med. And then we have these inhibition techniques for the muscles that we want to inhibit. Remember yesterday? This is an inhibitory course. And I can guarantee you, not a lot of those are stretches. A lot of those are stretches by myokinematic muscles of the body. The body is inhibiting and stretching out a muscle, not you. Not the body's muscle is stretching and inhibiting that muscle. What's the technique for that? But look at those first 4. Do you see those first 4, everybody? So let's keep that in the back of our mind. You don't have a lot in your appendix that's going to go around other muscles. Let's switch back on page 42. I think we covered most of that. On page 42, we have a summary of the non-pathocompensatory test results of a left AIC pattern listed. So if you look at your adduction drop test and it's positive, it'll tell you kind of what's going on. We've already done all this, but it's kind of an overall summary. If anybody has any questions about that, now would be the time to ask. I think we did every one of those. On page 42, it says if you have a decreased left FAIR, it may reflect this. It may be reflected in the seated position. The patient's left femur is abducted in a left AIC pattern or a left AFER position. In other words, it's telling you what we talked about yesterday on what's going on based upon the way we're testing, based upon the way we were taught. We weren't taught to match legs and arms up to glenoids and acetabulum openings. We were just taught to sit. And so then you have to kind of think about, if you're in a pattern, what might be going on as a result of if you're in a position, what might be going on because of that position that you're patterning around. Today we're going to talk about the adduction lift test and the abduction lift test. With that being said, we're going to pick on some new people. Katie, you did such a really good job. Are you tired of reading? Just say yes. Okay. Pat, you're going to read today. Does that make sense? Would you mind, Pat? You're the person that should be reading, okay? We're going to ask you to read some of this stuff, and I'm going to bring a person up here, and we'll just look at how this test. Now, we're on page 43. Everybody turn to page 43. And it's called the Hruska adduction lift test. And Pat, you'll read what position to put the patient, and you'll say step 1. And then I'll ask you, I'm going to hand this to Jen, and Jen's going to just take us through every level. Level 0, level 1, and then I might ask you, Pat, what does that mean, okay, when you say a level. So we'll make it kind of fun. If you turn the page over to page 45, we'll kind of speed through the abduction lift test as well, okay? Let's make this as meaningful as possible, okay? Let's get somebody up here. Do you mind if I use you? Would you mind, Eric? Come on up. Come on up. Ben, come on up. Ben, take your gray shirt off, your gray sweatshirt off, and we'll put you down to a t-shirt, okay? We're going to check to see whether or not people can actually move through a frontal plane this morning. And then we'll reposition. Okay, let's go ahead, and I'm going to move this table a little closer so can you help me, Ben? Let's move it just a hair closer to the camera. There you go. Okay, so go ahead. What are we going to do? Pat, what does it say? Lay back up here.
Patient side lying, back rounded.
Okay, so you're going to lay on your right side. We'll start right here. And put your back. There you go. All right.
Uppermost lower extremities resting on the therapist's shoulder.
And before we get started, I just wanted to make sure you understand the position we're testing this individual in. And I think it's written in your manual about this test is named for, I'll read this at the very top of page 43. This test is used as a mild kinematic measurement with each grade reflecting muscle position, okay? Strength and neuromuscular ability. So there's 3 things going on here. We have mild kinematic muscle position. Write the word mild kinematic right under reflecting muscle position. That would be mild kinematic muscle position. Because the mild kinematic muscle, the mild kinematics of that muscle is going to change as he is elevating his hip. The muscle is going to actually go into a different direction on itself, giving its vector more or less power for certain planar movement. Does that make sense? So as the muscle's contracting, the muscle's taking on new properties. I got to get that in your head. He's going to be weaker in this first position. He'll be stronger in the last position because the muscle's in a different what? Position. So when you start this out, this is not a strength grade test. Because if it was a strength grade test, I'm testing up the weakest position in the beginning. I would probably consider putting him in the first, I probably would consider putting him in level 5 and see if he could go to level 1. I'm not going to do that. That's the old school. I just want to see if he can get to level 5. So therefore, this is a functional test. It is not a strength test. Number 2, it is therefore a strength test when we go through positions. If you wanted to look at the strength at each position, we could grade it out, but we're not going to do that either. That's an old school thought. Number 3, it's a neuromuscular test because his brain and his vestibular system and his neck has got to say, I'm going to allow you to do it. I may never have been in this position that I can recollect. I may not want my neck to let you do this. My body, my back says, no, 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 it hurts. It's a pain generator. So it's a neuromuscular test. But it's all 3 combined would make it a what? Functional test. This test is named for the leg which is placed on the examiner's shoulder. I'm about ready to sit next to this individual. Therefore, the test is named for the side that's on my shoulder. If his left leg is on my shoulder, that would make this a left Hruska adduction lift test. I think we said enough there. All right, you're back on. Okay, I just want to make sure you know what we're doing. So Pat, I'm sitting next to him. He's got himself curled up. Can you scoot forward a little bit? You'll put your hand flat. And Pat, he's got his shoulder. He's got his right shoulder on the mat. I've got my hand on his rear. I have his uppermost lower extremity resting on my shoulder. Okay, I'm trying to keep him neutral. I've got his knee extended. Pat, what's the next thing say?
The lower leg should be in a flex position.
Check, it is.
Maintain the pelvis in a neutral position. Do not allow the upper pelvis to rotate forward or backwards.
Check, check. Okay? Next slide.
Ask the patient to raise the ankle of the flexed lower leg to the upper knee.
So bring this ankle to this knee. Okay?
Have the patient raise the flexed lower knee while keeping the ankle to the knee.
Nice job. Check.
Patient will then raise the lower hip while maintaining the above positions.
Go as high as you can. Keep going, keep going, keep going, keep going, keep going, and keep going, and relax. Wow. Whew. What a great way to start the morning. Isn't that a great way, Chad? I knew he had it in him. Now we got to grade that. Okay? So let's go to the next slide. What does that say? Now, just remember what you just saw. We got to grade this guy. He gave us a grade. You all want to see it again? You want to see it again? I like feeling it. What a great way to start the morning. Here we go. A little more if you can. Have you ever had anybody check this before on you? Mm-hmm. It's awesome. Very nice. Go back on down. Wow. Gives me goosebumps. Can we do that again? No, I'm just joking. That's cool. That's really pretty cool. Isn't that cool? I'll tell you why it's cool. Let's find out. Pat, what does level 0 mean?
Level 0 means the inability to raise the lower ankle.
You sit down and watch this. I want you part of the show. Go ahead and sit down. Let's go ahead and sit down. We're going to bring you back up, though. I want you to see this, okay? The 0 means what?
The inability to raise the lower ankle off the mat or table. Obturator weakness of the flexed extremity.
So, if he didn't have whole control on his right side, he wouldn't be able to do that first step. He would not be able to take and raise, he would not be able to get. Inability to raise the lower ankle off the table would mean that he did not have control of that right obturator. He would not have control of his obturator, foramen, to do what with that leg? Externally rotate it. He isn't internally rotating it. He's externally rotated. Obturators stabilize with internus and externus. Okay? Let's go to the next slide.
Just to clarify, Ben was laying on the opposite side of this picture. So if this lady in the picture couldn't do it, it would be left up.
Would it help, Jen, if I put him on the other side right now and do the other side for everybody in the room?
Might help.
Come on.
Just so you see the mirror.
I love Jen. She's in my first row every day. Isn't she cool? She's thinking about you and the home viewer right now. So let's put him on this side. Chad, thank you, Jen. What side is this? What is this called? What's the name of this test over here? The right adduction lift test. Let's not make any interferences on this. Let's just see. Let's put the hand down. See what he's got. Puts his hand down. Brings the hip forward. Can you bring it forward a little bit? But can you bring your shoulders back a little bit? Can you bring your body forward a little bit? So your whole body come forward. Good. Can you? There we go. I'm gonna keep that hip forward. Okay, Ben. Got it. You ready to do this again? You know what to do? Bring that ankle to that knee. Bring that knee up in the air and go up as high as you can. Give me all you got. Keep going. Keep going. It's probably just a tad bit weaker. I can use the word weaker. But look where he's at. Everybody got it? Go back on down. That will help. Okay? Have a seat. There we go. So does he have at least a 0? He's breathing. So he's got a 0. What's level 1, Pat?
Level 1 is the ability to raise the lower ankle to the upper knee. Inability reflects either weakness of the FA external rotators or the AF stability of the active extremity.
Go back to level 0, could you, Jen? Read this one again. Inability to raise lower ankle off the mat or table. Inability to raise the lower ankle off the mat. Next slide. Inability to raise the lower ankle to the upper knee. There is a difference. Inability to raise the lower ankle means he has no control. And trust me, there are patients who cannot even think about bringing up their ankle off that mat. So we can stop right there. They need to really get some awareness of where their obturators are. And they need to figure that out. We're going to go through that program. This one says now, bring that ankle to the knee. Raise it up to the knee. Pat, what does it also say? Inability to what?
It reflects either weakness of the FA external rotator or the AF stability of the active extremity.
Okay, or the AF stability of the active extremity. Again, stability of the active extremity. Which is the active extremity? The left one. He's got to have AF stability, acetabular stability of that left one. He may not have that. In other words, to get the stability, he really at this point will feel his left acetabulum move down into that mat before he even starts. He'd have to feel some stability of that A. Let's go to the next one, level 2. Pat, what does it say?
Level 2 is the ability to raise the lower knee and ankle. Inability reflects instability of AF and weakness of adductor magnus and obturators, or an anterior tilted and forwardly rotated pelvis with accompanying FA-IR weakness, second degree long position of IC adductor and short position of the glute min, med, and TFL.
On that level, if you go, all take your pens and pencils and write down the word myokinematic restoration. Okay? You're taking a course for that. Because the position those muscles are in right there, if you cannot move into a level 2, you got to get them in a myokinematic program that repositions the patient. Because they cannot overcome the position with the test that I'm using. They're in a frontal plane test, and they can't do this, Drew, because they don't have myokinematic capability for functional performance in that position. So I'd have to stop, I'd give them a level 2, I'd stop, and I'd have to reposition and maybe try it again. But it's saying, because of a forwardly, anteriorly tilted, rotated pelvis. So stop. Would you continue to say, I know you can do this, Ben. I know you can do this. Come on. Or let me help you a little bit. Because at that point, they'll be using one leg to help that right leg out. The back. It'll be all back. They'll start to extend. Now, he definitely could do that, right? So we got him at a level 2. Let's go to the next slide. Jen, anytime you want to pop in, pop in. Now we're at the ability to do level 3. Can we do a level 3, Pat? What does it say?
Level 3 is the ability to maintain above position while lifting lower hip off of the table slightly. The inability reflects weakness of the FA stabilizers on the extended extremity, including the short head of the biceps femoris and adductor magnus, and possibly bilateral AF stabilizers, including muscles of the pelvic diaphragm and lower gluteus max.
Inability, let's break it down. Inability reflects weakness of the FA stabilizers. Circle the word F on this.